Welcome everyone to IS-PEC Talks, Bridging Evidence to Policy and Practice in 15 minutes. Today I have the pleasure of speaking with Dr. Sivan Spitzer, an organizational sociologist and the principal investigator of HEAL, the Health Equity Advancement Lab, based at the Azrieli Faculty of Medicine at Bar-Ilan University. She's also the deputy director of SPHERE, Social Precision Health Equity Research Endeavor, a $75 million 10-year initiative to reduce health inequities in the Galilee. Dr. Spitzer's research is grounded in a deep commitment to health equity. Her work focuses on identifying, designing, and evaluating organizational strategies to reduce inequities in care, especially for disadvantaged groups such as minorities, individuals of low socioeconomic status, the elderly, and people with disabilities. Sivan uses organizational change and implementation science frameworks to explore how health systems can translate equity from a stated value into concrete system-wide action. And we're going to learn from her today how to do that. Sivan, thank you so much for joining us.
Thank you for having me.
So I'm not sure how we're going to do all this in 15 minutes, but we'll try. And if not, we'll just have to take back.
Great.
So first tell us a bit, your background is in sociology. So how did you come, what drew you into focus on health systems and implementation science?
Well, the truth is I'm the proud daughter of a nurse. So I guess it was always somehow related to health policy. And very early on in my master's already, it was clear that health was something that was really interesting. Health, just like education, just like other pillars of society, really embodies the differences we see between different members of society, which is something that has always interested me. And coming from sociology, it merges, I think, well together in terms of my theoretical background as well. So, and living in the Galilee and being part of the social geographic periphery, that was another aspect. So it really embodied all of my areas of interest. And very quickly, it became clear to me that actually my sociological background was really relevant to the big challenges we have in health systems, health policy going forward.
Okay, and just for those of you that don't know the lay of the land in Israel, the Galilee is in the northern part of Israel. So it's part of the northern part of Israel. We have different regions up there. Can you talk a bit about HEAL and SPHERE and what inspired the creation of those two initiatives, and do they overlap, and if so, how?
Sure. So I guess if I have to kind of focus the different challenges that were always relevant to me as a health equity researcher, and there's really a kind of a clear pathway from my PhD to my postdoc, which I did abroad, to then becoming a full-time researcher. And that was, how do we translate equity from value to action? A lot of the research that we have around health inequities, health equity, is focused on these 30,000-foot statements of let's infuse a culture of equity to draw change, or all kinds of statements like this, which to me was, okay, well, what does it mean? I couldn't understand, what does it mean? How does it work in practice? And my research is always focused around that area. How do we translate equity from a value-laden concept to pragmatic real-world action? And so when I became a faculty member of the Azrieli Faculty of Medicine, it was clear to me that my lab would focus on the translation mechanisms from value to action, and how do we take health equity endeavors, interventions, and actually make them pragmatic real-world intervention. And about in 2019, after I had an opportunity to actually initiate and innovate and think of an endeavor that would help the Galilee minimize the health inequities that we see. So it was really harnessing again my background, my research background, and my research interests, and creating actually a synergy between my lab, HEAL, and the initiative I set up, which is SPHERE. So they're highly related. There's a synergistic relationship between the two of them. And what SPHERE allows me to do is really have an endeavor which is a real-world initiative, a large-scale national initiative, which allows really to create a sandbox for testing different interventions to reduce health inequities, using cardiometabolic disease as a case study to see how can we better help people who suffer from great inequities around chronic disease, specifically cardiometabolic disease.
So can you give me a concrete example of how this looks, taking, this is our value, and as you said, we want to act on it. We don't want to just talk about equity. Can you give me what does that look like in practice?
So first of all, it means that you create tools, first of all, to map health inequities on the ground. So we're very good at mapping and observing the disparities, but we're not always do that. Sometimes we do that with epidemiological data, but they're not necessarily focused on environmental data. They're not necessarily a holistic approach. We don't always see the organizational mechanisms that take apart the systemic differences that we have between organizations and how they actually try or do not try to implement different initiatives. So first of all, it's developing different mapping techniques. And what we do, for example, when we enter a town and work with a town, is that we map the entire ecosystem, which means using, for example, social and network analysis to see the connections and how interventions come into play, who's part, who's not part, who's part of the discussion, who works at what frequency. So it's really looking at it very pragmatically. How many times a year, a week, a month do you actually work on a project to reduce health inequities? Who are your partners? How does that work? So it's starting from that to creating strategic plans to harnessing here. This is where implementation science comes in. Harnessing the different strategies we have, implementation strategies. We know today what's more effective, what's less effective, and in really seeing the differences in outcomes and creating behavioral change, which is one of the things we want to do in reducing cardiometabolic health inequities. So how do we create interventions which, again, bringing the knowledge and then look at actually, I would say the big focus is on process outcomes more than they are on, at the end of the road, what happens. We want to understand the pathway. We want to understand what's going on. We want to understand what works for whom and what situation and why. And so we really focus on those mechanisms, looking at intervention strategies that, as I said, the analysis between different actors and different players, and understand the outcomes.
Is there one intervention that you could say works more than others?
Well, I mean, yes, I think we're seeing, and there's a lot of literature coming up on this, but in the world of health promotion, for example, a lot of the focus has been on awareness interventions. We know that their effectiveness is minimal, to say at least, in terms of behavioral change and reducing health inequities. They're almost ineffective. Yet a lot of the budgets and that we see, a lot of the investments goes to health awareness, health promotion initiatives, but really they have no effectiveness. So actually creating a whole new system where you build an infrastructure, which is actually, the awareness is really a small part. I'll give a concrete example, but health behavior change becomes actually the focus. So for example, if you're a town and you have high obesity measures in kids, and you see that one of the problems, for example, in the Arab community, is that they don't have the infrastructure for exercise. So you build a walking trail, but you don't always build a walking trail. You create time within the schools. You work with the schools to create specific dedicated time for using the walking trail as part of their everyday exercise program within the school. So you don't just talk about the importance of healthy food or exercise, but you actually create an infrastructure and built-in strategies for using that infrastructure for behavioral change rather than focus on health awareness. You use then sensors to see how that walking trail is used throughout the day. And then you also have the metrics and the data to see, is it effective? Are people using it? And that's how you kind of really create different interventions that are focused on not only creating the infrastructure, but then how do you create the usability around that using different implementation strategies?
I love your focus on awareness. I always say, I know I'm not supposed to eat the potato chips and the chocolate and whatever, but that's not going to change my behavior, right? It's what are the different infrastructural elements, whether it's not letting that type of food in the house, whether it's making sure there's more of the other stuff available, easily accessible, etc. So you gave an example at the organizational or the system level. Have you done interventions at the individual level as well?
Well, we work more I would say at the meso level than the individual level, but we do work with patients as well. So working through the health system, for example, at creating patient-focused care for people at the residing at the social geographic periphery, creating different precision type or personalized approaches. So for example, if you want to minimize the transition from pre-diabetes to diabetes, which is still a kind of a reversible, you have a window of opportunity, it's still a reversible change of time, then, some people would say, okay, if we have and just talk to our family physician and have follow-ups with our family physicians, that's enough. Some want phone consultation and not in-person meetings. Some want to also have a dietitian involved. Having patients working with a health system to create different strategies which would be personalized to each patient has proven, without any fancy digital innovation, just by going, looking at the different intervention strategies, making sure that they adapt to patients' needs, we've been able to reduce by 40% the transition from pre-diabetes to diabetes. Wow. So
that's huge.
It's huge. Sometimes it's nothing fancy. It's actually understanding the guidelines, understanding patient needs, and creating the right intervention strategies. And this is, again, where implementation science comes into play so nicely, that you can really see not only the process, but then, the outcomes, which are so meaningful.
Wow. So are there, and maybe this is the finding, are there any findings from your work that have totally surprised you and maybe changed the way you approach implementation?
I think I'm not sure that they surprise me. I think I always came in knowing that working in the real world, I have to have make sure I wear my boots every day because I'm going to sink deep in the mud. So in that sense, it's never like if I would say, okay, I'm going to really be patient and give it and say it's going to take 6 months. I now know that it's going to take a year, right? So everything is always double time. Maybe that's still surprising to me, no matter how hard I push. The real world has its own kind of time frame, and things, take a lot slower than you wish or you want. But I think in terms of intervention strategies, I think what has reassured me is when you think innovatively and out of the box, and when you're able to find the angle where you're able to answer the question, what do I get out of it for your partner in the innovation? If I'm able to answer that question, I'll be able to kind of put my foot in the door and get the intervention going. If I'm not, it's not going to happen. And so this is kind of my key question that I always ask. Have I been able to answer for my partner the question, what do I get out of it? And always view, it's not a person I'm doing an intervention on or an organization I'm doing an intervention on, but rather that they are my partners in this intervention. So kind of my 2 tips for my own personal guidelines, which I've learned, I guess, through the years. So maybe not a surprise, but still something that have been meaningful lessons.
Right. And that's so huge. The user partnered research, or to partner with the organization or the patient groups or whatever to help design the research questions. Because you and I don't do our research. We have labs or research centers, but we don't really have labs. It's not where we're testing things on mice and they do exactly what we want, et cetera. We're really
Exactly. It's people. And so they have to be your partner for things to get going, and they have to understand that it's important, and then there's going to be a benefit for them just as much as a benefit for science or a benefit for you, or it really has to be a joint effort.
Right. Yeah. Okay, so just to end, looking forward, what advice would you give to others trying to embed equity into health system change efforts?
Keep it real. Be very grounded, very pragmatic. Make sure that you're able to define what equity means in this specific lens you're working on. What are the anticipated outcomes? But more, I would say the focus should be again on process. We need to write the manual for how to reduce health inequities. We still don't have it. And not just document them. So those kind of be my tips. to make sure that we're focused and we don't use kind of the blah, blah, big 30,000-foot statements, but keep it very grounded and very real. What does equity mean in this specific context? And how are we going to make sure that it happens?
Amazing. Thank you so much, Sivan, for your time. And we will link to some articles when we post this so that our students and our listeners can learn more about how to incorporate health equity into their health system change efforts.
Thank you. Thank you for having me.